Thank you, and thanks for the opportunity. Also, thank you for joining me on an evening to hear more about a topic that's really important to me, postpartum pelvic floor health, and actually became more important to me after my own postpartum experience. So I hope I can provide some useful information for you and also answer any questions you have. So today we're going to be addressing a few of these objectives or questions. What happens to the pelvic floor during and after delivery? What are some common postpartum pelvic floor disorders? And what kinds of treatments are available for these disorders? And before I jump in, I just wanted to address what a urogynecologist is, because it is sometimes or more of a unique subspecialty within OBGYN. So it's a physician that has training in both obstetrics and gynecology, and then additional fellowship training in female pelvic medicine and reconstructive surgery. So we treat pelvic floor disorders, including prolapse and disorders of bladder and bowel control throughout any of the decades, but today we'll be focusing on the pregnancy and postpartum period. So the fourth trimester and beyond, this is that time after delivery. It's a period of extreme transition for both new and experienced parents. And I think we're really starting to focus on this time of recovery as a country and realizing how important it is for maternal health. There's many aspects of postpartum care. So that includes stressors involved with the infant feeding plan, if there's any complications of the pregnancy or with the baby, mental health, of course, chronic health conditions that patients may be dealing with. And then on top of all of that, also the physical recovery. And why is a focus on physical recovery important? So up to 60% of patients will experience one or more pelvic floor disorders after delivery. And that will persist for up to 8 to 25% of patients 1 year after delivery. And this in turn affects health, it affects well-being, self-esteem. It's been associated with development of depression and anxiety. And it often is accepted or talked about as part of a quote unquote normal recovery. And today I just really want to highlight that even though these conditions are common, they're not normal, and there are treatments for them and ways that we can improve quality of life. And I think I just wanted to bring up this quote from a recent editorial that I thought was powerful. There's been a lot of quote unquote silence around the postpartum time and a feeling of lack of support. And this particular quote says, female pelvic floor disorders are and have always been common, but a lot of patients not knowing how common their condition is may feel lonely, isolated, and ashamed. This is particularly true in the postpartum period, and it's disheartening to see a sense of shame and failure overshadow childbirth and parenthood, when in fact it should inspire awe and respect. And so addressing some of these disorders and conditions and giving them attention hopefully gives people back some dignity and respect during this period. So what does happen to the pelvic floor during childbirth and throughout pregnancy? So we're really starting to reconceptualize the events of delivery as really a birth injury. Even if it's a short-term injury, it can have long-term effects. So the birth injury itself occurs with the stretch and strain during pregnancy, and also particularly during a vaginal birth when the baby's passing through the vaginal canal. So one can be nerve injury, and the primary nerve involved is the pudendal nerve, which supplies much of the vagina, perineum, rectal function sensation, and undergoes a considerable amount of stretch and strain. The muscles that are primarily involved are the levator ani muscles. And you can see in this drawing on the right, it's highlighted in pink color. These act as a kind of a supportive bowl or hammock underneath the pelvic organs. And with that stretch and strain on those muscles, it can lead to different pelvic floor disorders that we'll talk about. There's also a considerable amount of soft tissue trauma and remodeling of the vagina that occurs. And this next picture shows some of that. So again, there's this nerve, muscle, and also bony attachment, stretch and strain, which does recover over time, but that short-term injury can also have long-term effects. And so the picture A on the left shows the pelvic floor not under any strain. The yellow are the nerves. The red is the muscle, and the purple is the connective tissue. And you can see just how much strain it undergoes on the picture, in picture B on the right, during pushing or during delivery, and pushing during delivery. And there are some additional risk factors for development of pelvic floor disorders that have been associated. There are many, so I just highlighted some of the more significant ones. So vaginal birth in particular is associated with a little bit higher risk, although a cesarean section is not entirely protective. An operative delivery, so this means usage of forceps or vacuum-assisted delivery, can also sometimes be increased risk for a pelvic floor disorder. A episiotomy, and then a birth weight greater than 4,000 grams or 8.8 pounds of the infant. So what types of postpartum pelvic floor disorders are we talking about? So we're going to go through each of these one by one and just talk about what the symptoms are and also treatment. So first, perineal lacerations, also known as obstetric anal sphincter injuries or vaginal tears. Urinary incontinence, which is involuntary leakage of urine. Pelvic organ prolapse. Anal incontinence, which can be leakage of gas or stool. Persistent pain, and then pain with intercourse. So first we'll talk about vaginal tears. So these are also known as perineal lacerations, and then a subset of them are known as obstetric anal sphincter injuries, also abbreviated as OASIS injuries. And these are tears that occur when the baby is passing through the vaginal opening. So this is an image if we were looking from the legs up into the to the vaginal canal there. And you can see as the infant's head is passing through, there can be tearing of the muscles and the soft tissue. There are different types of lacerations or tears, and they're characterized depending on the extent of damage to the perineum or extent of the tear. So they range anywhere from 1st degree to 4th degree. A 1st degree is when it's the mucosa or just skin layer of the vagina. It might be just a small tear. A 2nd degree is when the skin and also the perineal muscles have been affected. A 3rd degree is when it goes down towards the anal sphincter. And then a 4th degree in the bottom right here is when it also has torn from the vaginal opening to the rectum. And these 3rd and 4th degree lacerations are what constitute the obstetric anal sphincter injuries, OASIS, and they are specifically have an increased risk of complications and pelvic floor disorders. These only occur in up to 6% of deliveries, but there can also be unrecognized injuries of the anal sphincter. Even if you have just a 2nd degree, there sometimes can be damage to the sphincter that isn't seen at time of delivery. So what does recovery after a vaginal tear or laceration look like? So spotting and yellow discharge can be is common and can last for as long as up to 6 to 8 weeks. And that occurs as the wound is healing and the sutures dissolve, because we primarily only use dissolvable suture for these repairs. Perineal care can be really important to recovery. And this involves a 10 to 15 minute bath twice a day with gentle patting dry afterwards. It can just be in a bathtub with a small amount of warm water. The use of a peri bottle or a topical anesthetic. There is our topical lidocaine sprays that can help with comfort. And then a bowel regimen is important to keep the stool soft and easy to pass so that there's less strain and less discomfort during recovery. What are some warning signs after recovery or during recovery to look out for that may indicate a complication? Especially, again, with the 3rd and 4th degree tears that go into the anal sphincter or that rectal area, any kind of persistent pain, increase in bleeding, a foul-smelling discharge, fever, or passing stool through or gas through the vagina. These can all indicate potentially a wound breakdown, a wound infection, or a fistula which is when a connection can develop between the rectum and the vagina during the healing process. Treatments. So early intervention and evaluation is really important, and is one of the reasons that we established a postpartum pelvic floor clinic at Baystate Medical Center. And this includes evaluation by a pelvic floor specialist and just a little bit closer attention to that physical recovery aspect we were talking about before your 6-week visit, or just in the weeks or days or weeks following delivery. There may be a need for reoperation or medications like antibiotics if necessary. And then for persistent pain, which can happen with especially complex tears, or really with any vaginal tear, pelvic floor physical therapy can be really useful for that. And a lot of our counseling also has to do with what will happen with the next delivery. Is this going to happen again? Because it can be a really traumatic experience, and a lot of patients can have PTSD from that type of recovery. So the risk of repeat injury can be anywhere from 4 to 12%. Overall, and this is based again on kind of data and the likelihood of the tear happening again, vaginal delivery is usually recommended unless something like a persistent stool leakage or problems with bowel control exist. But again, this is shared decision making with your obstetric provider. And so there are, even if the permanent stool leakage doesn't exist, it's really, an opportunity to discuss with your doctor about if you choose to have a C-section or what that would look like. That's certainly something that is open for discussion and something you can choose, especially given the PTSD that can be associated with that type of delivery. Next, we'll talk about urinary incontinence. So the first type of urinary incontinence that is probably the most commonly seen during and after delivery is stress urinary incontinence. And this is any stress or pressure on the pelvic floor that can happen because of cough, laugh, sneeze, running, heavy lifting, any type of activity, and the leakage of urine that occurs with those activities. So during pregnancy, there are reported rates of anywhere from 45 to 60%. So again, really common, and even postpartum, 6 to 34%. There is a slightly higher risk of this developing again with the vaginal delivery, although it's not, the risk is not non-existent with the cesarean section. The pictures below are just demonstrating. So we talked about kind of the stretch and strain and pelvic floor damage that can occur with delivery. And so with stress urinary incontinence, that damage to the pelvic floor occurs at the level of the support of the urethra, which is the tube connecting the bladder from where you urinate. And you can see on the left the lack of urethral support here that can happen because of pregnancy or during childbirth can lead to poor support. And so any pressure on a full bladder, or not, it doesn't have to be full, can lead to leakage because the urethra is not able to stay closed like it used to before the damage occurred. So what can we do to treat this type of leakage? One aspect that can be reassuring for some patients is that it does tend to resolve for more than 75% of patients by 1 year after delivery. But that's a long time to be dealing with this type of leakage. And so there are treatment options during this period of time or afterwards if it persists. And that includes pelvic floor exercises or Kegels, pelvic floor physical therapy, both of these, which we'll be talking more about in a few slides. Incontinence pessaries. So these are support devices for the urethra, and they provide the support by sitting in the vagina and providing the support from underneath where the urethra and bladder sit, as you can see in the bottom picture. There are reusable and non-reusable pessaries. So the top picture shows one of the silicone reusable pessaries that we can fit in the office for you. And the idea is if it's in place correctly, it should be comfortable. It should you should be able to go around about your activities without it being aware that it's there. And a lot of our patients will use these situationally, especially in the postpartum period. So if they're returning to work where they may do more strenuous activity, or returning to exercise, or just, taking care of other kids while they're recovering and having to lift little ones up, this can help just with some of that bladder control while the pelvic floor heals. The middle picture is one of the disposable devices that can also be used. And it's almost inserted like a tampon into the vagina to help support the bladder and urethra. If the symptoms persist, there are surgical options, which I'm happy to answer any questions about. But just because I was focusing on the first year postpartum, the more conservative treatments are kind of what we tend towards. Urge urinary incontinence is another major type of urinary leakage. And this is a sudden and intense urge to urinate that may be associated with leakage and also urinary frequency. And this is really, really common during pregnancy, especially due to a growing uterus. And as there becomes less room in the abdomen with more pressure on the bladder. So it is very common, but it's less frequently reported after delivery. Although it can develop as an issue later in life and is commonly experienced by many of our patients. So what happens, this is less of an issue of support or from injury to the pelvic floor, and more because of a overactivity of the bladder. So on the left, it shows just a picture of a normal bladder that when it's full, the bladder gets a signal to contract and we empty our bladders. But with overactive bladder or urge incontinence, before that bladder is full, the detrusor muscle or the muscle of the bladder starts contracting, creating that really strong urgency and occasionally leading to leakage. Treatments for this. So often, again, after delivery and that first 6 to 8 weeks after delivery, the urge incontinence resolves for many patients. However, if it does not, or develops later on, some of the treatment options that we usually start with behavioral changes. And so avoiding bladder irritants, things like caffeine, stopping fluids 2 hours before bedtime for those that are getting up frequently at night to urinate. Fluid restriction or just decreasing fluids to 40 to 60 ounces a day, although this can be challenging if you're breastfeeding or pumping, or in general, just drinking more fluids in that postpartum period. Bladder training is also another thing that we talk to our patients about. Pelvic floor exercises, Kegels, and pelvic floor physical therapy, again, can be very helpful for urge incontinence as well. And then if those don't work, there are medications and third line treatments. So definitely a very prevalent condition and one that we have lots of treatment options for. Next, we'll talk about fecal incontinence. So this is the accidental leakage of gas or stool that may or may not be associated with fecal urgency. And I included some of the numbers here because I wanted to just highlight that even though a lot of these conditions are more prevalent or more higher risk if you have a vaginal delivery, fecal incontinence is one really that it happens pretty similarly across vaginal or cesarean delivery. The one area or type of delivery that is a higher risk to develop is if there is a 3rd or 4th degree tear or that oasis injury we had talked about. So the rates there at 6 weeks and then 6 months after delivery are 26 to 17%, whereas for a vaginal delivery or C-sections 10 to 11, and then down to 7 to 8% at 6 months. And a majority of patients do see a resolution completely by 3 years after delivery. And while that's reassuring in some ways, that's still a long time to be dealing with what can be socially limiting and really a challenging disorder to deal with. So what can we do about it? The first thing is really focused on changing stool consistency and frequency, usually with dietary changes and then fiber supplementation, particularly psyllium fiber. There are also medications that can help bulk the stool and help to decrease leakage. Pelvic floor muscle control, and this is, again, pelvic floor physical therapy, has been shown to significantly decrease symptomatic leakage of stool and gas. And then if those treatments don't work, there are advanced therapies and even surgeries that can help address this type of lack of bowel control. Next, we're going to talk about pelvic organ prolapse. So pelvic organ prolapse is when the pelvic organs drop from their normal position due to weakening of muscles and connective tissue. And that can happen, during pregnancy and after delivery. Although vaginal delivery is more highly associated with this, and the risk of prolapse increases with the increasing number of vaginal deliveries. Symptoms can include a vaginal bulge, having to push in on the bulge to empty the bladder or bowel, and feeling a sense of pelvic pressure. And this illustration at the bottom is just showing what some patients describe seeing if they use a mirror or if they feel something in the vagina. It may be a bulge that occupies the entrance of the vagina, as seen on the right. These are just some images illustrating the types of pelvic organ prolapse. So the picture in the top left here is demonstrating just normal support. So this is a cross section. There's the bladder, the vagina with uterus and cervix, and the rectum. And you can see they're pretty intimately stacked on top of one another. And then the pelvic floor muscles, which are not pictured here, act as a small bowl or hammock to support them. But with the weakening of that support, first, the picture to the right shows bladder prolapse, and you can see the bladder is bulging down into the vagina. Again, this is nothing dangerous or life-threatening, but it can cause really bothersome symptoms. So some people describe having to lean forward or push up on that bulge to fully empty their bladder. Lots of a bulge sensation or something sitting there. They may be unable to keep a tampon in because of the bulge. And it can almost sometimes also be described not as painful, but almost like an achy pressure. The bottom left here shows the prolapse of the rectum into the vagina. Similar types of symptoms, except that more stool related. So some patients have to push in on the bulge to fully empty their stool, or they describe having to go to the bathroom multiple times to empty. Can be of course, very bothersome. And then uterine prolapse in the bottom right corner here, which shows when the uterus is what's bulging into the vagina. And you can present with a combination of any of these or it alone. And so we take special measurements to determine exactly what is prolapsing. So will the prolapse go away? So for a majority of the patients, again, similar with stress incontinence, for 75%, their bulge symptoms are actually resolved by 1 year after delivery. And that just speaks to how dynamic that first year after delivery is in terms of pelvic floor healing and remodeling. So there's just a lot changing. And, often we'll see patients at various points, 6 weeks, 3 months, 6 months, 1 year, and there is a significant change even by 6 months. There is some suggestion that breastfeeding patients may have a delay in healing until after they wean. There's a loose association with that. And what are the treatments for symptomatic prolapse? So we treat this based on how much it's bothering you. Again, it being there on its own, if it doesn't bother the patient, does not have to be treated. but pelvic floor exercises and Kegels can help to make the bulge not necessarily go away, but less symptomatic. Also, thinking about protecting the pelvic floor in the postpartum period. So exhaling when lifting to avoid straining and to decrease pressure on the pelvic floor, avoiding constipation, and working on strengthening core muscles, which we'll talk about in a later slide, can help to support the pelvic floor and regain some of its strength to potentially make the prolapse less bothersome. Pelvic floor physical therapy again. And then there are, instead of incontinence pessaries, there are pessaries specifically for prolapse that can help symptomatically. These can be really useful, especially in that first year. So if a patient has the knowledge, okay, I have this prolapse, it's likely to resolve. I'm going to work on my Kegels, but it's still bothering me. We often have them come in for a pessary fitting. At least it's something you don't have to go home with or have to use, but it's an option that can help with that discomfort. And then we do have many varieties of surgeries for prolapse. But again, because for so many patients it resolves by 1 year postpartum, we kind of, make a plan and where surgery fits in if it's chosen by the patient. So I've talked a lot about postpartum pelvic floor physical therapy or pelvic floor physical therapy in general, and it can truly be amazing. I wish it was part of postpartum care universally, as it is in some countries and some health systems, because I do think that everyone, regardless of type of delivery, should be offered pelvic floor physical therapy. But it can be hugely beneficial for many of the conditions that I've talked about: stress urinary incontinence, urge urinary incontinence, the prolapse, fecal incontinence, also for chronic pelvic pain, and then pain with intercourse. Usually it consists of anywhere from 4 to 8 weekly sessions, with more as needed, depending on the type of progress the patient is making. And something to know that makes it unique from other types of physical therapy is that it does involve internal vaginal work. And that's, because the Kegels are a huge part of it, and the pelvic floor muscles need to be engaged. And so I always like to let people know that before they sign up, because not everyone may be comfortable with that, or may want to try something on their own before trying the physical therapy. The main issue, though, is that, and this is a national problem, there is a large shortage of pelvic floor physical therapists. And I think that will increase over time. But in the interim, if you're not able to get in for a pelvic floor physical therapy appointment, there are ways to do self-directed pelvic floor muscle training, especially if your doctor or a pelvic floor specialist is able to tell you if you're doing the Kegel exercise correctly, or if you know that you are. That can just be really useful, because that can be a large part of the initial visit to a pelvic floor PT, is just making sure that you're doing those exercises correctly. If you are doing them correctly, just to mention a Kegel routine that can be performed. So it's when you pull in and hold the pelvic muscles, squeezing for 3 to 5 seconds, and then relaxing for the same amount of time. You want to repeat that 10 times and aim for doing them 3 times a day. In the beginning, especially postpartum, again, you have that stretch that occurred and the strain. So the nerves are still going to be weak, as are the muscles. And so initially you may only be able to hold it for anywhere from even 1 to 3 seconds. But every week or every few weeks, you want to try and hold it for 1 second longer until you're able to hold it for a 10-second squeeze. And I tell a lot of patients they may not get to that point until 6 to 12 months postpartum, or they might kind of max out at 5 to 7 seconds, and that's okay. You'd want to try not to hold your breath and try to keep your stomach and back muscles relaxed. Also trying not to contract the gluteal muscles or the buttocks, because you want to focus really on kind of lifting the vaginal muscles. You may start to see improvement as soon as 6 to 12 weeks, depending on the condition. But again, with that really dynamic recovering pelvic floor, and these Kegel exercises, it can kind of help accelerate recovery. This is just a handout from a website that is the American Urogynecologic Society. They have lots of patient fact sheets and handouts that can be really helpful. It's at augs.org. In addition to doing the Kegels on your own, I think one of the hardest aspects or most difficult is just accountability and remembering to do them. And I know this from personal experience as well. It's easy to say, oh yeah, just do Kegels, but to actually implement it and remember it when you all are juggling a lot of, a newborn and other aspects of postpartum recovery, it can be difficult to remember. So Kegel apps actually can help by just providing reminders and also even reminding you how to do the exercise and keeping track of how long you're able to hold the exercise. So I just included some examples: Kegel Trainer, My Kegel Pal, Squeeze Time, and these are all free on the Android or Apple app stores. I get questions sometimes about Kegel training devices, and while they can be effective, currently the studies show that they're not clearly superior to doing the exercise on your own, assuming that you're doing them regularly. And they can also be expensive. So it's not something I like to necessarily recommend, just because it may not be accessible. And again, we haven't seen evidence that it's necessarily better than doing the exercises on your own. And what are some safe exercises in the early postpartum period that can be done? I included just some that address core strength and that can help with pelvic floor recovery. So diaphragmatic breathing. This is a type of breathing that can prep your core to increase strength and also help before you increase any intensity of exercise. So it's demonstrated on the right here, but the idea is to inhale. And when you inhale, that's when the pelvic floor, abs, and rib cage all open or relax. On exhale is actually when the pelvic floor should be lifted, abdominal muscles also contracted, and then the rib cage closed or smaller. And you want to try and hold that for 5 seconds with the idea of working up to 5 to 10 at a time and 2 to 3 times a day. So this is something that can be really started within a few days after delivery, depending on your level of comfort. Walking is definitely a great way to slowly start activities. Pelvic tilts, which are pretty small, subtle tilts of anterior or posterior, meaning front or back tilts of the pelvis that can help to strengthen the core and back muscles. And then on the bottom right here, the cat-cow stretch that can also strengthen core and lower back muscles. So all of these are kind of things that can be done before that 4 to 6 week kind of check-in with your doctor or midwife, and are safe to do as long as you're kind of listening to your body and when it's comfortable for you. So we talked about some of the other conditions. I separately put pain and sexual dysfunction because sometimes the Kegel exercises, while they're treatments for other pelvic floor disorders, they can actually worsen pelvic pain that's existing or sexual dysfunction if there's any kind of existing pain or recovery of the muscles or the pelvic floor. So for perineal and pelvic floor pain, generally the larger the tear or more significant of the tear, the longer the pain is experienced. And there does seem to be less pain with a spontaneous tear as opposed to an episiotomy, although sometimes episiotomies are needed for a safe delivery. At 12 weeks postpartum, there have been studies that show that pain is more common in breastfeeding patients. And that we'll talk briefly about that, but can be because of a different level of hormones. Most pain does resolve by 8 weeks postpartum, but for a small percentage of patients, it can persist. And it can also lead to a developing of a hypertonic pelvic floor. So this is, if you almost can think of like a Charlie horse in the pelvis, or like a strong muscle response. So after that type of, after the delivery, which is a type of trauma to the pelvic floor, it can respond by the muscles contracting to the point where it can be very uncomfortable. It can occur on just one side or both sides. And again, if you have that type of tense pelvic floor, Kegels can actually make things worse. So what are some of the treatments for pain of the perineum, or the vaginal opening area and pelvic floor? So vaginal estrogen is something that can really help with vaginal dryness, pain at the entrance of the vagina, and also pain with intercourse. And this can be for any postpartum patient. It's a topical cream that's applied and kind of restores some of the decreased hormone levels in the vaginal tissue, and does not have to be used forever, but especially in that first 6 to 12 months after delivery can be helpful. Topical anesthetics or pelvic floor suppositories, also pelvic floor injections, are some other treatments that we can offer. And then pelvic floor PT, I can't overstate enough, can help also with persistent pain. And what about sex after delivery? So sexual dissatisfaction and dysfunction are highly prevalent, or really reported by many of our patients. 64% sexual dysfunction, 70% sexual dissatisfaction during the first 12 months after delivery. And I think there's kind of an expectation that once you're cleared for intercourse, that it's just you're supposed to just go back to it. But there's a lot of patients that are experiencing pain and discomfort, and that can take some time to resolve. There's similar rates across vaginal deliveries and cesarean sections, especially after that vaginal tear. If someone had one, has healed after that 6 weeks after delivery, the rates are the same. I just included this graph just to show how common a lot of the sexual dysfunction complaints are. So lack of interest in sex, lack of lubrication, pain during sex are some of the most common. And what's interesting here is that they evaluated 1,500 women and asked them questions about sexual dysfunction. And on the left here is before pregnancy, what the reported rates were. And then the symptoms really peak at 3 and 6 months after delivery. And by 12 months after delivery, it goes back to baseline, meaning whatever they were experiencing before delivery or before even being pregnant is what the levels go back to. But also just to highlight that these issues are, really highly prevalent or common outside of pregnancy and delivery. And so really, an area that we can do more and improve for a lot of our patients. What are treatments for sexual dysfunction? So pelvic floor physical therapy, vaginal estrogen can help. Vaginal dilators can also help depending on the type of pain, or if the vaginal opening is really contracted and the muscles are really contracted. I didn't mention here, but we do have a sexual health clinic at Baystate as well, and also sexual health therapists, which can be helpful. And this app is it's called Rosie, and it was designed by an OBGYN specifically to address issues related to sexual health. So maybe not specific to the postpartum period, but it has a lot of educational information and videos that can be helpful. I briefly mentioned breastfeeding and pumping and pelvic floor disorders. So this is breastfeeding generally puts us into a decreased estrogen state, and as a result, it can cause a delay in the healing of the pelvic floor. It may be associated with delay in pelvic floor recovery, although there's mixed data about that. But ultimately, it doesn't appear to be associated with any long-term effects or any long-term development of pelvic floor disorders. So it's really just specific to that period of time. So one of the questions that I'm always interested in kind of thinking about and researching is, can we prevent pelvic floor disorders? So it's challenging because pelvic floor disorders are multifactorial. There is a genetic component. There are aspects that we have no control over. But there is some suggestion that performing pelvic floor exercises, so those Kegel exercises during pregnancy, can actually help to prevent urinary incontinence from occurring, or if it does occur, it'll be resolved sooner. It's unclear if you already have incontinence during pregnancy, if they help. However, there's limited data and limited studies, so it typically won't hurt and likely does help. There is some data to suggest that improved fitness during and after pregnancy can be protective from developing pelvic floor disorders in the future. And also improved fitness during pregnancy has been associated with a decreased time in labor, which in turn sometimes can decrease the risk of pelvic floor disorders developing. But mainly, we don't have much data here or information or studies. So I think that is kind of maybe the next focus over time. So what are some of our takeaway points from this talk? So pelvic floor disorders during and after pregnancy are common, but not normal. So you are not alone, and there are treatment options. Early postpartum follow-up for complex vaginal tears can help with recovery and monitoring for any complications. So having an extra point of contact before your 6-week postpartum visit. Many pelvic floor disorders will resolve on their own by 6 to 12 months after delivery. Kegel exercises and pelvic floor physical therapy can help with recovery. And there are non-surgical and surgical treatment options for pelvic floor disorders. So this brings me to a new clinic that we've created at Baystate specifically to address these types of issues. And it's for patients that are pregnant or up to 1 year postpartum that are experiencing pelvic floor disorders. And, we've talked about why it's important, but really the early intervention, education, treatment of pelvic floor disorders in pregnancy and postpartum. I think a lot of pelvic floor disorders are maybe dismissed or kind of accepted as normal. And so may not get the treatment they need for. Sometimes patients are coming, after decades of having these symptoms. So we really want to empower patients to have the knowledge and options to do something if they choose. It's also an additional focus visit on the physical aspect of recovery, in addition to your routine 6-week postpartum visit. And we really want to make it a collaborative care with your obstetric provider. So it's a referral-based clinic. We communicate with them and really work as a team to get our patients where they want and need to be. So the idea is it's comprehensive postpartum care. So our team has urogynecologists, pelvic floor physical therapists, sexual health therapists, and also ability to refer to any subspecialties as needed. So gastroenterology or colorectal or urology. And the goal is really to provide whole patient care. So not just focusing on the physical recovery, but also having resources for lactating patients, mental health resources, or support or referrals for support groups. And just briefly, what would a visit look like? So there's a specialized intake form. We do a targeted pelvic exam, depending on what the patient's comfortable with, looking at tissue quality and healing, evaluating for any of the disorders that we discussed, and then strength testing or ability to perform that Kegel exercise. Possibly a pelvic floor ultrasound depending on symptoms, and then a discussion of treatment options. So I want to thank you for your attention, and I'd love to answer any questions.
Thank you, Dr. Maheshwari. That was really a fantastic presentation. And I appreciate your time. And there are a few questions. If you don't mind, I'll read them to you. The first one is I'm having issues with my rectum. I pushed a 9-pound baby and I had hemorrhage often.
Yeah, the definitely one of the risk factors for developing issues with the rectum and whether it's bowel control or bulge symptoms is a larger baby at time of delivery. And I'm not sure if it's hemorrhage or if maybe it's hemorrhoid, but either way,
yeah.
Yeah, maybe it could be either. But yeah, so in our clinic, we'd be able to evaluate for the issues that you're having with the rectum and help to resolve whatever is bothering you.
What can be done for the pelvic organ prolapse because it hurts to have intercourse?
Yeah, so yeah, and it can be uncomfortable. So I think the first thing would be an evaluation to see, is it the prolapse alone? Is there any associated hypertonicity? Remember those tense pelvic floor muscles I was mentioning? Because if it's a combination of all of those, it may need to be addressed in multiple different ways. But pelvic organ prolapse itself, again, the pessary wouldn't necessarily work because it does have to be removed for intercourse, but certainly there are surgeries or maybe even the exercises depending on the extent of the prolapse. So I think an evaluation to kind of see what stage the prolapse is at would help, and also to evaluate if there's any accompanying pelvic floor pain or issues that can be treated in other ways.
Thank you. Next question. Will the prolapse put you at greater risk for a miscarriage with another pregnancy?
Yeah, great question. The studies show that does not put you at increased risk of miscarriage, even if you have uterine prolapse and the cervix is outside of the vagina, doesn't appear to increase your risk of miscarriage.
Thank you. We have a couple of questions. You mentioned a third line treatment. What is that specifically?
If it's yeah, I didn't go into the specifics of some of the third line treatments just because sometimes they fall out of the window of the first year postpartum. For third line treatments for overactive bladder, there are actually it's something called sacral neuromodulation, which is actually a nerve stimulator for the bladder, similar to a pacemaker, except for the bladder, and also bladder Botox. For fecal incontinence, the third line treatments include also sacral neuromodulation because it that works actually for bladder and bowel control, as well as other types of nerve stimulators and surgeries specifically to address the anal sphincter or where the stool passes through.
Thank you. Yes. You see that if you wanted to read that next question, what's
Sure.
plus oasis related to fecal incontinence?
So the obstetric anal sphincter injury. So those are the third and fourth degree lacerations. So those occur, those are vaginal tears at time of delivery that involve the anal sphincter and rectum. And if that type of tear occurs, there's an increased risk of stool leakage and bowel control issues. So that's what in that, probably talking about that table, what I was referring to there. And then the last question is, how do you diagnose pelvic organ prolapse? So yeah, and also great question. So we diagnose it based on symptoms, but also when we do an exam, we actually take measurements of the pelvic floor, and we may take the measurements while the patient is bearing down, so almost pushing for a bowel movement, just to see how the vaginal tissue moves. Also, sometimes when patients are standing, because a lot of patients, their prolapse is more symptomatic with gravity and at the end of the day after they've been on their feet. So we take different measurements, and then we're able to determine exactly what is prolapsing, whether it's the bladder, the uterus or the rectum. Next question looks like, I'm 10 months postpartum. I have unresolved symphysis pubis dysfunction. Is this a pelvic floor disorder? If so, what can I do about it? If not, do you know where I should go for help? Yeah, the pubic symphysis dysfunction is, and I didn't talk about it as much because it's more of a skeletal and bony dysfunction as opposed to muscular or nerve related, but it can be extremely painful, and I'm sorry you're going through that. It's technically a type of pelvic floor disorder. Pelvic floor physical therapy can help. Depending on the nature of the pain, PT, like I mentioned, and also someone with more specialty in musculoskeletal dysfunction. But if you were to come to our clinic, it could definitely help you find the resources for that, and also some things to help symptomatically that you probably are already using, about things like pelvic girdles and support devices. Next question is, I'm a second year OT student. How can I help and get education and support into the community? I love that. I would love to work with you. So I can provide my email, but that's something that I'm interested in as well. And I think that education and support is exactly what we need to focus on in a time when a lot of people don't have much support in that postpartum period, or might be embarrassed to talk about it. So I would be happy to talk with you kind of more about that over email or in person. Are any of the pelvic floor PT sessions covered by insurance? If not, what's the approximate out-of-pocket cost? Yeah, so this is, yes, it should be covered by insurance. And generally it is, if it is, most of the PTs that we partner with are covered by insurance. Some are not, and are more a private-based service, but depending on the insurance, you can submit a claim to be reimbursed for that money. It can be, I'm not going to lie, it can be challenging to make sure that money gets back to you. So the approximate out-of-pocket cost for more private pelvic floor PT can be anywhere from $200 to $300 a session. But the ones that we typically refer, but again, they have a long wait list, are covered by insurance. Next question. So severe pelvic floor and low back pain for 2 years after delivery. Interstitial cystitis and painful bladder syndrome. So the question, have you ever seen the impact of a birth result in chronic pain or rheumatologic conditions? For example, fibromyalgia can be caused from trauma like car accident. I'm curious if birth could also be a cause. Not sure what direction to take persistent pain that's 2+ years postpartum. Has seen multiple specialists and gotten testing and no answers yet. I'm sorry you're going through that. That sounds so challenging. There have been some studies that have shown not a direct link, but there may be some association with delivery and development of painful bladder syndrome, more with cesarean sections than vaginal deliveries, but still we don't have enough information to say anything definitive. So I do think that there can always be some association that we just aren't even aware of. So I'm not entirely sure about the fibromyalgia link. I think there's probably just limited data, but I wouldn't rule out a potential connection. And certainly if any of the pain that's persistent is in the pelvic floor, we do see patients with IC and painful bladder syndrome, and we'd be happy to see you in our clinic. And can you describe what a pessary is again, please? Yeah, so this, it's a support device that is either, the ones that we use in our clinic are reusable. They're made from a medical grade silicone, and they either support prolapse or they can support the urethra and bladder to help with incontinence, which specifically stress urinary incontinence. So it is reusable. It is reversible. So if you don't like it, you don't have to use it. But some patients get a lot of relief from their symptoms from it and are really pleased with how it works. I'm 32 months postpartum. How I still contact the Baystate clinic you mentioned. Who should we contact? Yeah, so you can call our clinic number, which is, do we have somewhere listed?
Yeah, I was looking on the website for it.
Yeah, it's 413-795-8764. And you'll be connected to a patient care representative or one of our nurses, and just mention the pelvic floor disorder that you'd like addressed, and we can get you scheduled for a visit. If you mention the postpartum aspect, it will be specifically in the postpartum clinic. So and we'd be happy to see you.
We're at time, and I think you've answered all the questions, Doctor. So thank you very much for all this wonderful information and for the work that you do helping women. So thank you very much, and I hope you have a great evening.
Yeah, thank you. And thanks for this opportunity. It really was great.